Hello and welcome to the Two View, the cutting-edge educational show for PAs and nurse practitioners in emergency medicine and urgent care. My name is Mike Sharma. I'm a practicing emergency medicine and urgent care PA in the Dallas, Texas area and an adjunct professor of PA studies. Here with me is my faculty partner at the Center for Medical Education, nurse practitioner Martha Roberts. Hello, Martha.
Hello, I'm Martha Roberts, and I'm a nurse practitioner in Northern California. I'm also faculty for the Center for Medical Education and professor of nursing. Hello to you all.
Hello to you all. We are back on our regularly scheduled schedule, folks. And just 2 more months till our big advanced camp in Las Vegas, the Advanced Emergency Medicine Boot Camp. I was just talking to Fred Rahabian today, actually, about our shared presentation about EKGs. Really excited about that. But without further ado, let's dive into our segments today. Our first segment, the wet read, where Martha and I get 60 quick seconds or so to talk about something that caught our eye.
Talk about caught my eye. You know that I'm right on this one. As you may have read in the news or on your email alerts from the U.S. Drug Enforcement Agency, known as the DEA, it's moving forward with the plans to move marijuana from a Schedule 1 to a Schedule 3, jumping all the way down. Forget about Schedule 2. This is going to now be a Schedule 3 controlled substance under the Controlled Substance Act. This was just announced by the U.S. Department of Justice officials previously last week, and we are still in May while we're recording this. So as you know from Graduate School 101, drugs, substances, certain chemicals used to make drugs are classified into 5 distinct categories or schedules depending upon the drug's acceptable medical use and drugs abuse or a dependency potential in the United States. And the abuse rate is a determinant factor in the scheduling of the drug. So for example, Schedule 1 drugs have a high potential for abuse and potential to create severe psychological and or physical dependence. As the drug schedule changes, Schedule 2, Schedule 3, etc., so does the abuse potential. Schedule 5 drugs represent the least potential for abuse.
There is a listing of the drugs and their schedule at the Controlled Substance Act scheduling or CSA scheduling by alphabetical order, this website that describes some of the chemical nerd stuff, like the basic or parent chemical. They don't really get into all the different salts and isomers and enantiomers and all those other things, which may also be classified as controlled substances. This list and lists like it are general references. They're not a comprehensive listing, but it gives you kind of the broad idea. And Martha, are we going to have a link to this? It's a website, basically. Is that correct?
Yeah, so I'm going to put all this stuff up there for everybody to take a look at.
Oh, good. That'll be on our website at the 2view.fireside.fm. That's the number 2view.fireside.fm. Everything we talk about here today will be at that website.
Yeah, so moving forward on this, it means a lot for the plant and for its reputation. It also matters to you because you're going to possibly be wondering, well, what about who, what, when, where, and why people will be asking for this? Remember, marijuana isn't cheap. It can be, but what will this mean for prescription drug regulations? Increasing costs, dispensing. There are so many doors and questions that are now opened up with the scheduling change. Some other reminders, let's do a comparison because now that is also being judged and categorized. What is this change saying about potential addition of your practice, changes, misuse, how its usefulness is really going to be proven for certain treatments of certain illnesses. Schedule 1 drugs, substances or chemicals are defined as drugs with no currently accepted medical use and high potential for abuse. Some examples of those include heroin, some peyote, and formerly now marijuana.
Formerly, yeah, no longer. Schedule 2 drugs are drugs with a high potential for abuse with use that potentially leads to severe psychological or physical dependence. These drugs are considered dangerous to some degree, and a lot of our combination products we use that have less than 15 milligrams of hydrocodone in them are a part of this. And so things like trade name Vicodin is in there, but also things like cocaine, methamphetamines, methadone, hydromorphone, meperidine, aka Demerol, oxycodone, fentanyl, even things like Dexedrine, Adderall, and Ritalin. These are all kind of essentially methamphetamine salt preparations. All of these are considered Schedule 2. And as you're realizing, Some of these drugs are drugs with potential for abuse and diversion, but we use these things on the regular for legit medical purposes as well.
Right, even cocaine, you can get liquid or powder cocaine for reconstitution to use for numbing anesthesia. Often use this in foreign body removal in the ear. So this is something that your Pyxis may or may not have. So remember, Schedule 3 drugs. Now, we're breaking this down so you know about this leap from marijuana going from number 1 to number 3. Schedule 3 drugs, where they now have jumped down this whole schedule of substances and chemicals defined as drugs with a moderate to low potential of physical and psychological dependence. Schedule 3 drugs, abuse potential is less than Schedule 1, as we've reviewed here. And some of those include products that contain 90 milligrams of codeine per dosage unit or less. So that's like your Tylenol with codeine. Ketamine is in there, anabolic steroids, testosterone, and now that's where we find our weed. So just putting this all in perspective, Schedule 4 drugs, these are all substances or chemicals with a low potential for abuse and risk of dependence, and some of those include Xanax, Soma, Valium, Ativan, Ambien, Tramadol. And we go further into Schedule 5, which we sort of break down here as, things like even antidiarrheals are in there, antitussives, analgesic purposes from those, and really lower preparations of codeine and so on and so forth. So you can take a look at that whole list. But there are many studies that show dependency for benzos. That's actually really impressive, yet they still remain as a Schedule 3 category. There's also some literature that suggests that marijuana can be an addictive substance. There's other studies that show that it isn't. So in addition, how will marijuana be formulated? Is it just flower, oils, pills? How will we come up with a reliable therapeutic dosing? Where will it come from? Will we have pharmacies that grow its own, or will patients get it from a side corner store down in Sacramento or wherever? I have so many questions. I just hope that we get to hear more about this in the coming months. There's a lot of information out there. Do your own news search and check out the DEA website. And again, we've posted some of those links.
Well, you're talking about the DEA. I'm going to talk about DKA. Something that stuck with me ever since the first time I saw this in a patient was the idea of euglycemic diabetic ketoacidosis. And this is the idea that a patient's sugar, serum glucose specifically, can be under 250 milligrams per deciliter, and yet they can also be suffering from life-threatening ketoacidosis. This is one of the parts of emergency medicine that I love. When you have to take a strong clinical call based really purely on history and physical exam and your knowledge base. And this decision you pull the trigger on may be counterintuitive. It may be even contradicting the lab results you have in front of you. And you make that strong clinical call and you save a life. I love that part of emergency medicine. I also like pulling foreign bodies out of people's orifices, but I digress. This euglycemic DKA is relatively rare. Currently, about 3% of patients who have DKA have euglycemia, again, a glucose under 250. And it can happen, historically, it was happening in patients who were, let's say, pregnant. They weren't absorbing nutrients because they had bariatric surgery, or there was some other carbohydrate limited state, excessive vomiting. So if you're barfing it out the front end, you're not absorbing it in the intestines or the stomach. If you're doing some sort of a keto thing where you're intentionally restricting carb intake, or some sort of malnourishment, which is not unusual in all of our patients who have social determinants of health impacting their care. But a relatively new and rising reason for euglycemic DKA is the use of the drugs called sodium glucose cotransporter 2 inhibitors, or for short, SGLT2 inhibitors. These drugs were not around when I went to PA school. The first of this class of drugs that treat diabetes was canagliflozin. This is trade name Invokana. We've all kind of heard about that drug, Invokana. First approved by the FDA in 2013, and more in this category have followed since. These drugs can be recognized by the ending of the generic name. All of the generic names end in gliflozin. And the way I remember the mechanism of action of these drugs is that when you take them, glucose flows into your urine specifically. SGLT2 inhibitors inhibit the kidneys from reabsorbing glucose, so more urine glucose, less serum glucose. Less serum glucose, less insulin secretion, but more glucagon secretion. More glucagon secretion, more fatty acid breakdown, and viola, more ketone bodies and more acidosis. The JAMA Network Open published a research letter in March 2024 about a multi-center retrospective study from Australia. Hey, good on you. Of a couple dozen DKA cases, some in patients with classic DKA, in patients with type 1 diabetes, but also some other patients who had type 2 diabetes and had this SGLT2 inhibitor associated DKA. I think their findings are especially pertinent when we're having to do what we talked about in the last podcast. We're boarding these people who should be inpatients in the ED. And that situation, some of us find ourselves in all day, every day, boarding these inpatients in the ED. What this study from Australia found was that despite SGLT2 inhibitor DKA patients looking better, so to speak. I mean, they had lower hemoglobin A1Cs, they had lower serum glucoses on presentation, they even had lower ketone levels than the average type 1 DKA patient. The group of patients who had SGLT2 inhibitor associated DKA, these supposedly healthier patients, took on average twice as long to clear their DKA to resolve as a type 1 group, an average of 36 versus 18 hours, double. Okay, so why is that? Researchers weren't quite sure. Maybe it's like, there's this sliding scale, right? Like when someone's in DKA, you kind of do a couple things to make sure they're safe, and you throw them on the sliding scale, and kind of like then there's a lot of like nurse-driven care in terms of like check the sugar, give a certain insulin level. These patients in the SGLT2 inhibitor group had a higher body weight in general. And we know on the sliding scale, the lower you get on your serum glucose, the less insulin you're getting. So these bigger patients are getting less insulin. Maybe there's something there, and that's why it's taking longer for the DKA to clear. Maybe there's some sort of residual effect of the SGLT2 inhibitor drugs. It's hard to say. The researchers acknowledged the limits of this small sample size of their study and the retrospective nature of their study, but they suggested, and this is where we're going a little bit off books, so just like be aware that the evidence here, the evidence base is not super strong, but it's reasonable. Okay, so when you decide to do this, what I would suggest is you kind of talk to a collaborating clinician and say, hey, I have this idea for this patient who's going to be sitting here in the ER. What do you think? Do we think we could do this safely? They suggested it would be reasonable to turn it up a little for these patients having SGLT2 inhibitor associated DKA. Let's give them a little more glucose so we can give them a little more insulin so that we can suppress that ketosis better and faster, which ultimately is what we're trying to fix. Not their sugar level, not their insulin level. We're trying to fix the ketosis. We're going to be seeing these drugs more and more in our patients. These gliflozins seem to also be helpful in patients with CHF, which is not going away anytime soon. So it's something to think about the next time you manage a patient taking SGLT2 inhibitors and in DKA and boarding in your ED.
Yeah, so, my marijuana segment, and then, that hurts my brain just a little. But what I will say is that you got to be checking sugars, okay? I remember working with a really great Dr. Adam Cohen. He was at Southwestern Vermont Medical Center, and I remember him coming up and asking me, hey, how's your pediatric patient with DKA? I'm checking, and I go, oh, they're okay. We just went in there and talked. He goes, no, that's not why I'm asking you. Like, have you got a repeat BMP? What's their DEXI? Okay, like you guys were shooting the crap, but hello, what are the numbers? So just remember to get a few blood sugar checks throughout this patient's visit. You aren't done with just one or two. Point of care is also very helpful, especially if these patients are looking sick. And, you don't want these patients hanging around because I get busy and testing and treatments can be delayed. So move them, hand them off, whatever you need to do, and get multiple numbers. One or two numbers, not enough.
Yeah, as much as these patients, again, they generally look healthier than your type 1 diabetes DKA patients, they still have DKA.
Yeah.
And so they're still having a life-threatening condition. So you may have to really advocate for this patient to be the next one that's brought up
Yeah.
to the ICU or the PCU or wherever, instead of someone being like, well, they look fine. Like, why are we going to fast track them? Like, no, these people can kind of go south in a hurry, especially if you're getting busy. And what are the odds of that in your emergency department?
Right.
Well, speaking of getting busy, it's about to get time to go to Vegas again. Okay, so July 9th, our pre-course day, EKG workshop and imaging workshop as the appetizer, the amuse-bouche before the advanced emergency medicine boot camp. That's going to be July 10th through 12th in sunny, it's going to be really sunny, Las Vegas, Nevada. Yeah, bring your moisture-wicking attire for those days. It's going to be pretty toasty in July, but the AC is rocking inside of the casino, so no sweat about that, literally.
Yeah.
Martha, how about our main emergency medicine, the original, the OG boot camp? That's going to be in December, correct?
Yes, it's in December, but I just want to point out one thing about the advanced camp that's July 10th through 12th for the main portion of the camp. I want to
Mm-hmm.
just give you a couple of topics that we're talking about. We're going to talk
Oh,
about avoiding errors, medical decision making. We're going to talk about how to make the ED ouchless, which is always a fascinating topic. We're going to talk Diane Birnbauer gives a absolutely incredible two-part series talk called A Wolf in Sheep's Clothing. Wonderful, wonderful cases that she talks about. We got neonatal emergencies. We've got a transgender patient, a new talk here for the session here in the emergency department. We've got stuff on transfusions, airway, medical legal quicksand, all kinds of stuff. We even threw some oncology and post-intubation management in there. So much more. Come hang out.
there's one in particular that I'm very interested in. It's entitled Pregnancy Care in the Post-Roe Era, Things You Need to Know. And, I live in a state where, this, of course, is a topic that can really bring about some strong feelings on, all the different sides of this discussion. And I think that at the very least, I think there are a lot of like facts and myths about what is kind of, allowed and not allowed and recommended and not recommended in caring for patients who are pregnant in early pregnancy, and what should be done there. What is the best way to care for the patient, regardless whatever your personal beliefs would be. Whatever your beliefs are, you need to know what the law is
Right.
and what these patients may be seeking. Because, as you know, like patients hear things like, they are pregnant and they're worried and they hear these things about how they're supposed to act when they go to the ER. So again, put your personal feelings aside, of which I have very many strong feelings on this topic, and understand that your patient out there who is pregnant may be suffering in many different ways, and they need your reassurance, they need your guidance. And I think Dr. Birnbaum would be a great person to give said guidance
Yep,
and said reassurance.
she's working very diligently on this. So I'm very excited that we are able to bring this stuff to you. So, all right, let's move on to segment 2. It's our dry scan where we penetrate a little deeper into 2 other topics.
Yeah. So speaking of rashes, you may get to see this summer. So maybe you'll have a rash when you come to the EM boot camp. Hopefully not. Hopefully you'll be
Yeah.
rash free during your stay. But maybe you'll look around and see rashes on other people as you're throwing some dice or playing some cards, and maybe you can kind of diagnose them for free while you're at it.
Yeah, fun times. So this may seem really basic to some of you, but we want to talk about this because it's very common for an ER visit or urgent care. So rashes, skin issues remain a large part of the quote emergent visit and should be mastered by any practitioner working in urgent care or the ED. And first, I always like to remind people of the quick and easy approach to any kind of rash. So ingrain some sort of pattern approach, thought process when you see a rash sign into the waiting room or be placed in a room. And I like to use this 3-part approach for every single patient, even when I know what the rash is at first glance. I've been fooled. So step 1 is to use my mnemonic, which is SLIT. That means S is for subjective, L is for listening to the lungs, I is do they look ill, and T is for timing. So this mnemonic also works for upper respiratory infections, colds, and flus. I listen to the lungs on all these patients because some viral exanthems can cause a rash, especially in kids. So since many rashes can accompany this viral illness, asking some other questions about being sick or feeling sick will help break this down for you. And step 2 is to determine if this is truly an allergic reaction that needs immediate treatment, or has signs and symptoms of angioedema before dismissing the patient and doing oral treatments, even if that's going to be indicated. So, step one, use your mnemonic to look at this patient as a whole. Step two is this a life-threatening medical emergency and if there's an airway problem? And then step three is to grab a friend. So bring that friend with you, see if they agree, and it's a really great way for you to also get to know more rashes and the people that you work with. So it only builds skill and rapport.
Martha, you and I have the benefit of working in, a county, a hospital, but what comes with that, because you work, that's an academic facility as well, correct?
Right.
So, I mean, like you have dermatology attendings and residents that you can call and they'll actually see your patient in the emergency department, like, which is
Right.
just like mind blowing for those of us like me who come from community. And it's like, dude, I could admit a patient on dermal and not even see them when they're admitted for a week, even though I consult them. So, especially in our line of work in academic emergency medicine, and we've been talking about this at my shop in certain cases where it's like we'd see a patient and go, I think the patient's going to be okay, but maybe I shouldn't consult a specialist. Especially in our line of work, Martha, and you kind of know this too, I'm sure, when it's so easy to consult a dermatologist and your rash is something you don't like, it does not fit cleanly into a particular box that you are like a hundo or darn near 100% sure on. If it's a weird rash, look, when it's so easy to consult dermatology and you don't, and there's a bad outcome, like that burden refalls on you, like it's going to be asked of you, like you can consult any dang specialty you want to. Why didn't you here? So it's different for those of you in the community world where it's like, yeah, there's not even a dermatologist in this county, let alone at my hospital. And so you have to understand, like, who are my friends that I can call in? Am I going to do some sort of a telehealth consult? Is that an option in my shop? Do I work with a collaborating clinician like a senior PA or NP or a physician? Can I bring them in? Like, understand who your resources are. Is there a dermatologist out there in your community that you can send a weird rash to, and you can call them and be like, hey, I don't know what's going on with this person, but I really like them to see you in your clinic. Can you make that close follow-up? So, where you work really determines what that follow-up can be. And in those patients who maybe look a little bit sicker than the average bear, like maybe you are going to transfer this patient for more tests at some sort of a, higher level of care. And it can sound weird to say, yeah, I've got this RAS patient I'm really concerned about, I'm going to transfer you to your shop. But just be prepared to like fight the fight, start talking about things that are concerning. Do you see things like petechia? Do you see purpura? Do you see hemorrhagic bullae? Like some of these things that may be concerning for more serious rashes, that can be kind of the thing to hopefully tip the balance and go, all right, we'll see this patient for you.
All right, well, calm down just a minute on the transfers because I want to talk about the summer rash, which
Okay.
isn't really going to be life-threatening, but can be quite painful. And in future podcasts, actually next month, Mike, I'm going to talk about eosinophilia and some allergic responses in the white blood cell count and what it means to you and your patient, which is actually kind of really interesting. So I'll save that for later. But yeah, getting to talk about our summer rash now, and also in the winter, depending on your commitment to the mountaintop and sun glare. So people do get sunburns in the winter. But let's talk about sunburn and burns that cause irritations of the skin and or possibly allergic reaction afterwards. And usually that's, in short, a reaction to a topical that they've put on the sunburn.
Yeah.
So we're going to talk about that in a moment. But according to the World Health Organization, burn injuries of all kinds and causes affect more than 11 million people yearly, and more than 180,000 people die. Approximately 95% of deaths, they occur in low-income and developing countries, and that's due to high costs. Modern therapies are not available, and that's unfortunate for our underdeveloped countries. And we'll talk about how third world countries have adapted in a minute, but poorly designed healthcare systems all over and low health expenditures per capita in low-income countries correlate with higher post-injury complications, which can lead to disability and death. Therefore, treating burn wounds in general remains challenging, particularly a cost-effective therapy. We want to come up with some ways to treat this. From big burns to small burns, it doesn't matter. A burn is painful, and they can get infected. bad, painful bacterial infections, and worst case, amputations, scarrings, and that can happen even with a bad sunburn.
In terms of the history, usually you'll get the history from the patient that they were out exposed to the sun rays for too long. So what do we do about this? Because people will come to the ER for sunburns. And so, there's no point in getting upset about that. We just have to kind of get ready for it and understand what the best practices are here. And also, maybe once you gain their trust, you can also suggest certain things so they don't get the next bad sunburn. So, in terms of treatment, you're treating sunburns like regular burns. It's that easy, like these are thermal burns at their core. And so you treat them based on any other thermal burn of that severity. Don't forget, there's a lot of drugs that we're slinging these days that can cause dermatitis or, a sun allergy, so to speak. Doxycycline is the biggest one out there. I mean, if a shift ends and I haven't prescribed somebody 7 days of doxy, I feel like I've done something wrong. I've missed out. I haven't seen enough patients, honestly. Those who use oral contraceptives as well can become more sensitive to sunlight. Tricycline antidepressants, if you're still doing that sort of thing, maybe for sleep or chronic pain. Statins, NSAIDs like naproxen or celecoxib. Diuretics like furosemide, hydrochlorothiazide, certain antihistamines and steroids. There are so many drugs that can cause sensitivity in your patients. And I don't know about you, but I kind of hammer the doxycycline, but I don't think I'm as good about counseling my other patients on those other drugs about hey, you really got to be careful. The sun's coming out, and you got to be careful with this sun sensitivity from the medication I'm just putting you on.
Well, you're welcome. Now you will be. So there you
I
go.
will. Thank you.
So the American Academy of Dermatology suggests at least 30 SPF or more, just in case you were wondering what the hard and fast number was, and to sit in the shade, wear hats, use umbrellas, long sleeve clothing, all those things. And what's the treatment? Well, we can start over-the-counter meds. And even some homeopathics, believe it or not, they may help. So acetaminophen can help for pain. Try that first. Topicals such as 100% pure aloe. We're talking about from the plant. You're going to avoid additives. Basically, what's happening is that the sunburn draws fluid to the skin surface and away from the rest of the body. So hydration is key. We want to give fluids orally, please. Leave the blisters alone. They are second-degree burns, and don't pop them. And you can also sometimes prescribe a hydrocortisone cream, but I'm going to talk about that in a minute. It is very controversial and at times not helpful. Cool baths, avoid hot water, and then, of course, monitor those skin blisters for signs of infection.
The American Academy of Dermatology also suggested that patients avoid cane medications. Okay, so our benzocaine containing creams and stuff like that, which is tricky because the patients are in pain. They go to the pharmacy and they go, well, this is for pain, so this must be good for me, okay? But these benzocaine and other cane-containing creams can irritate the skin that is already sensitized after the burn and further promote allergic reactions, okay?
Right.
And, of course, while you're already having a burn, don't get burned again, okay? Fool me once, shame on you. Fool me twice. One of those things, right? Yeah,
right.
So don't get burned while you're already burned.
Yeah, so again, avoid those combo products and creams. They're all just snake oils. And a bit more about aloe. Now, that's the key here that I wanted to get into. Not only does it feel better to put it on, it's easily absorbed once it's dry, and it doesn't get sticky. It's sticky at first, but then later it's not. So aloe vera is it's been used for the beneficial effects on the skin. Mainly, it's mucus gel filling in the leaf part, right? So you're going to crack it open. Don't rub the pointy part on your skin, which also can be used, of course, in cosmetics and pharmaceutical preparations. Some people even drink it. Mixed literature on that. But there are many randomized control trials for aloe. And when I say many, there are many. So it's kind of a fun internet search to do. And it's had a long history of medical use, dating back to cultures, old roots, Chinese, Egyptian, Indian. Over the years, several studies have been conducted on its pharmaceutical use, as I mentioned, and it's been used as an antibacterial, antiviral, anti-cancer, antioxidant, anti-inflammatory, skin protective, wound healing, regulating blood glucose levels even, and cholesterol levels. So you can do your own search on that. But according to a 2023 article in the journal Pharmaceutics in the article entitled The Potential of Medicinal Plants and Natural Products in the Treatment of Burns and Sunburn, a review. The paper includes articles from 2010 to 2022 describing clinical trials for single herbal preparations or their mixtures and animal studies of plants or plant extracts and their mixtures. So I took a look at this. Ton of things that help burns, many I've never heard of. Mike, did you want to talk about some of the things besides aloe?
I'm convinced that you've put some of these genus and species names of plants on there just to screw with me, honestly. Okay, you just wanted to like see how I was feeling on a Tuesday afternoon. Okay, and I'm gonna tell you, I'm up for the challenge. So here we go. Okay, there have been clinical trials showing herbal preparations from plants like Albizia julibrissin, Onebia euchroma, Centella asiatica, Hippophae rhamnoides, Lawsonia inermis, and then a mixture of Matricaria chamomilla and Rosa canina. And all of these things, and by the way, who hasn't mixed Matricaria chamomilla and Rosa canina once in their lifetime? If I've had a
Rose
million or
and
a nickel every time
chamomile.
every time if I had a nickel every time I mixed Matricaria and Rosa, I tell you, I'd be a rich man. Anyways, all of these things seem to, there are studies out there, but I mean, you can find a study that says anything if you massage the data well enough. There are certain studies that suggest, and I think here's the important part is, for a while, these silver-containing creams and bandages were thought as the gold standard of burn care until recently. Okay. And so, yeah, maybe there are these papers that suggest like all these, herbs and, like 12 herbs and spices, you can go down to KFC, I guess, and probably get you half of these. But, just because they work better than silver sulfadizine doesn't mean that they're things that you should be kind of like aggressively pursuing for your patients.
Right.
Okay. Yeah. And by the way, yeah, thanks. Silvadene, thanks for reminding me, is kind of like the trade name for this silver sulfadizine. For me, honestly, I go with the tried and true bacitracin. Like it's this soothing thing. It's inexpensive. And I don't feel that there's any benefit to silver sulfadizine over for your basic thermal sunburn over bacitracin. Also, some of these combination like triple antibiotic ointment. Patients think like, well, if one antibiotic is good, 3 antibiotics has to be at least 3 times as good. But a lot of folks, now that this being said, a lot of folks react to bacitracin too. But
Yeah.
neomycin, the neo of Neosporin, is also well known to cause dermatitis in some patients. So in the end, a lot of these plants are interesting, and if they're better than silver sulfadizine, I think that just means that silver sulfadizine kind of sucks, and not that these plants are much better than them.
Look,
Okay,
don't
so
diss the plants, okay? I mean, the studies were interesting. Look at the 10 years of data and all these randomized trials. I mean, hey, read them.
Martha, I know from segment 1 that you love your plants. Okay, so like, don't worry about that.
Oh, Lord. Okay. So, in conclusion, looking at aloe, burns, and other treatments, due to the diverse mechanism and action, antibacterial activity, safety, and all the herbal preparations, they're competing with controversial treatments in treating burns and sunburn. Like you said, are we really going to do this or not? But there's a lot of growing interest in this, and many companies are making creams and ointments with a bunch of chemicals that are unnecessary, ingredients that you don't need, so read the labels. There's still a lack of some clinical trials for some of these other things. So if you feel safe with Silvadene, fine. There's nothing wrong with doing some aloe, the real plant. I feel like, we might get into the weeds here if we go on talking about it. But,
Literally, the weeds.
Yeah, truly. Like, what strain of the plant? Like, how was it grown? Where? What's the age of the plant? There's so many variables. So, one quick word, though, on prednisone. And I wanted to talk briefly about hydrocortisone, and that's it. While prednisone seems to be ineffective at lessening the cutaneous sequelae of a sunburn, it may improve the systemic symptoms of potentially the fever that could come with it, the headache that can come with it. And so a brief treatment of 30 to 60 milligrams per day for 3 to 4 days, it can be used. And according to the Merck manual, this is something that you might want to try. Again, it's controversial. Of course, weigh the pros and cons and appropriate usage of oral steroids. Don't combine oral steroids with NSAIDs for the treatment. And prednisone is a powerful medicine, and it can have, of course, a lot of side effects, what we all know about. So Worth asking patients if they're already on it too. Remember, prednisone can cause thinning to the skin, which increases your risk for sunburn. But of course, if you have sunburn and you're treating it and you're staying out of the sun, could potentially have some help there. In regards to the topical corticosteroids in sunburn, NIH and JAMA's randomized double-blind clinical trial states that treatment with topical moderate potency or even high potency corticosteroids does not provide a clinically useful decrease in acute sunburn reaction when applied 6 to 23 hours after UV exposure. So I'd say skip those.
Well, so Martha, I don't know about you, but thinking about a different topic here, shortness of breath. Since the start of the COVID pandemic in 2020, I felt that I needed to make a change in the way I evaluated patients where the chief complaint was shortness of breath. And by the way, that's a really good, not to like plug it again, but there's a, what is the name of this here? When the triage note says SOB, that's the name of the talk at the
Yeah.
Advanced
I
Emergency
used to give
Medicine
that
Boot
talk.
Camp. Oh, really? Okay. So
Yeah.
there is a good talk about dyspnea about Dr. Robert Tubbs, MD, coming up here. But yeah, so when somebody has the complaint of dyspnea or short of breath, before COVID, I used to be a little more aggressive, frankly, with these complaints. I'd at least, even if vital signs, work of breathing, lung sounds were fine, I'd be like, all right, well, you say you're short of breath, so like, let me like get a chest X-ray, I guess. Good luck doing that during about April or May of 2020, okay? Because everybody came in feeling short of breath. I stubbed my toe and I'm feeling short of breath. I have a headache and I'm feeling short of breath. So, especially if the patient tested positive for SARS-CoV-2 or we had strong suspicion for SARS-CoV-2, as long as they weren't having objective signs of respiratory distress, and their SpO2 was solid. After a while, often I would just discharge them home without a chest X-ray or much else. Of course, as long as I'd satisfy the workup for any other significant condition that might cause dyspnea. If it looked more like it's SARS-CoV-2 and dyspnea, I wasn't doing a chest X-ray. I was really relying on the kind of clinical gestalt and then their pulse ox. But I'll never forget a young man who I took care of who had very dark skin, who came into the ED having already been diagnosed with SARS-CoV-2 acutely. And he was like, I feel fine, but I was told to come back in if my oxygen saturation went down. I checked it at home and it was 88%. And I was like, oh man, like it, but then I take a second look at this guy and he looked like really good. So of course we did our vital signs on him in the ED and our pulse ox said 94%. And other vital signs were really good as well. And the guy was like, I don't get it. And he reaches into his bag and pulls out the pulse ox from home, the one he had used, puts it on the adjacent finger on the very same hand that we had the pulse ox on, and his said 88%. And we like changed fingers and moved the pulse ox around, switched it, and sure enough, whatever finger he put his home pulse ox on, it read low. And whatever we put our pulse ox on, it read fine. So like, which one do you believe? Okay, well, in this patient, he was a young, otherwise healthy person, and like I mentioned, feeling really good otherwise. So we had a risks benefits discussion, the risks and benefits of doing further testing, maybe even admitting him because there was at least one reading that said he was hypoxic, but this patient ultimately declined further evaluation. He said he'd come back if he got worse, and off he went into the night. As the pandemic went on, though, it became clear that there were some issues in variability with readings with different pulse oximeters. So fast forward now to March 2024, the March 2024 edition of the journal Anesthesia and Analgesia. I know you're a rabid subscriber of that journal, Martha. Researchers conducted a prospective study of almost 150 people with varying darknesses of skin in this controlled setting. By the way, Martha, this happened in San Francisco, in your neck of the woods, where they could adjust the oxygen level for this patient, and they performed almost 10,000 paired readings, having a pulse oximetry with a finger oximeter, and they did an arterial stick. They got an arterial oxygen saturation and off that arterial blood gas, and they looked for patients where they were missing hypoxemia. And so what they described, this kind of misdiagnosis, was where the finger pulse ox said 92 plus, but the arterial O2 sat was below 88. You guys feeling me? Below 88 was the true oximetry, but the finger pulse ox said it was normal. So in patients considered to have light skin, By the Fitzpatrick scale, there was about a 1% frequency of missed hypoxemia. That's not bad, that's acceptable. In patients considered to have medium skin, maybe like me, there was a frequency of about 8%. However, in patients considered to have dark skin by the Fitzpatrick scale, researchers in this, again, prospective study measured a frequency of missed hypoxemia in just over 21% of their readings, 1 in 5 times. That is staggering to me. Okay, they tried to look for the gender of the patient, the age of the patient, were these confounding things, and they felt no, these things did not contribute. So the takeaway is this: if you are considering the possibility of your patient in front of you with dark skin having hypoxemia, and the pulse ox is kind of borderline, despite all you do to measure it. You find a good finger, you have them take some nice big deep breaths, and still it's it's kind of borderline. There may be a benefit to further assessing perfusion status in these patients with dark skin and borderline pulse oximetry by the finger. You may want to go all the way to resorting to getting an arterial stick and getting arterial blood gas to really know for sure, is this borderline patient perfusing or not.
Yeah, VBG is fine though.
Yeah, that's the thing, right? Is a VBG okay? I think a VBG is okay in our healthier patients, but I think.
Well, if this person is super sick looking, that's fine. I mean, I don't think anyone's ever going to criticize you for getting an ABG if that's what you wanted. But I'd get a VBG. And I don't think, that pursuing an airway concern is ever going to be criticized or questioned because, look at what you just said. So really fascinating. And I know that you were really interested in this because you sent me that article 4 times. So
I must have forgotten at least half of those times anyways.
All right. So moving on to segment 3, we're going to mix it up. We're going to spill over a little bit from our editorial release last month. We want to talk about a few of our weird and wild cases. I used to do this for Emergency Medicine News and the Procedural Pause. We talk about our weird and wild cases. We got a lot of really good response. So I wanted to kind of bring that back. And our feature today is going to be called Coming to an ED Near You.
Yeah, so some of these cases, and these are patients that I've really had to start understanding what my resources were available to me to bring to bear on these patients. And these are our patients that are at least moderately complex, that don't need admission but clearly have problems. We all know that coordinating care in the ED for patients is typically considered an outpatient function. Okay, so it's is this really my job? Is this more of a primary care practitioner's job? In the end, the patient's in front of you. And so, but maybe you've got a patient who has some complexity and they have a little more urgency behind their symptoms, and they require more aggressive coordination of care on your part before they leave the emergency department.
Yeah, Mike. So this is a good one. Seems daunting at first and impossible, but we worked it out. And I'd like to start with a case about a 25-year-old on hemodialysis, otherwise well patient who recently moved from LA to San Francisco. And the patient had an underlying renal disease at an early age and had been on dialysis for the last 5 years. He was working, well kept, chest, central venous catheter, living his life. He was non-English speaking, and he came to the department on a weekend night, quite late. His dialysis is usually Monday, Wednesday, Friday, and he was asking us to set up dialysis for him for Monday morning. Now, I can tell you, after working in the emergency department for a very long time, I know that dialysis patients take actually pretty good care of themselves. And when they have a known disease and they're young and they're like this guy, he's working and, on the move, they want to keep their catheter clean and they want to participate in all kinds of things in life. So to see someone show up and be like, I don't have a plan for my dialysis was kind of odd to me. So again, young, typically compliant patient showing up, just moved to the city, has zero plan, very concerning to me, but we'll talk about those other issues in a minute. First, note that this type of case, it's not normal. So what do you do? Where do you start? What are you going to figure out for this guy? The first thing I did was call our social worker to see if we had a direct dialysis transfer. Okay, so outpatient DaVita, for example, might transfer their patients easily. People do go on vacation. People do travel. It's possible for you to get dialysis in another place that's not LA, right? But they still need a nephrologist, though. So this can be accomplished, though. It can be. We can work on this. Unfortunately, our social worker wasn't able to help us with transferring from one clinic to another clinic. He didn't have health insurance in our county, and he was an immigrant. So our next step was to determine a plan. So what's the best
Yeah,
approach here?
this is a hard situation. Like we've all had those patients in which we feel like we spend like half of the care of the patient is spent on the phone
Yeah.
talking to people like pharmacists or hospitalists or other specialists. And I know the tendency is like I didn't get an emergency medicine to become a glorified phone operator, okay? But this is communication. At the heart, it's communication. And I see myself as kind of part of the safety net for patients. Like it's a real honor to work where I work at a county emergency medicine facility where like patients can come in and like throw themselves in the mercy of the court, so to speak, and be like, "Help me! I need help." And thankfully, I have a ton of resources to bring to bear. But what I need the most is the one resource I sometimes have the least of, which is time. But these patients require time, and that time is involved with asking them a lot of questions and trying to figure out, like, you know, what was the diagnosis exactly that you had? Oh, you're not sure. Okay, well, who would I call about that? How would I get more information about this? Where were you seen previously? A clinic in Los Angeles. You don't know the name of the clinic. Okay, no problem. Like, we'll continue to work this problem here. And so, like, it can require a lot of like asking the next question and asking the next question and asking the next question. But there are some, beyond doing the detective work, there are some other simple things that you can do as the EM clinician to at least nail down the dialysis on Monday problem.
Yeah. So get those questions answered first. Talk to the patient, see how much you can glean, um, and then ask these two really important questions. Do you have a history of hyperkalemia or electrolyte abnormalities? Now you can put it in layman's terms and be like, "Yo, have any of these things like with your potassium or other, you know." I'm trying to think what is layman for this. Just be like,
Yeah, it's hard.
have you had any complications from your dialysis, okay? And then you have to set up a baseline lab testing. So that's a CBC, a BMP, a MAG, a FOS, and as well an EKG. Chest x-ray for completeness for the CVC ports. And if they have a shunt, look at that AV fistula carefully. Is there even a thrill, right? These are all things that are pretty straightforward physical assessments that you need to do. And even if the patient is feeling well, these tests and exams are important for their dialysis the following day or the day after. And then we need to find an accepting nephrologist that's willing to take this patient on in the outpatient clinic. So that was sort of difficult for this patient, but we did it.
I was just thinking through, like, how would you kind of relate these, electrolyte abnormalities and their severity to the patient? I think an easy way could be, okay, so you've been needing dialysis for the past couple of years. How many times in the past 12 months did you need to be admitted to the hospital? And that maybe can get you a feel for the patient's adherence and also how brittle they are. And if they say, yeah, no, I have not had to go to the emergency department at all in the past year other than today, that's kind of reassuring because you probably know a lot of these dialysis centers will, at the drop of a proverbial hat, send a patient to the ER if they get a whiff that something is a little bit off as far as their electrolytes or whatever else. And so, like, that's very reassuring to me that the patient, potentially if this patient had never been to the ER in the past year, versus if he's like, oh, yeah, I've been admitted like 17 times in the
Yeah.
past year to the emergency department. It's like, oh, okay. So something weird is going on with your kidneys beyond just being in end-stage renal disease. I got it. So maybe that, if nothing else, you can get a feel for the severity and brittleness of this patient by asking about hospital admissions in the past year. Well, anyways,
Yeah.
That's just an idea. So what ended up happening to this patient?
So the patient, they got set up for dialysis after we plugged him into our system and his baseline labs were acceptable. The whole process took about 6 to 7 hours because our wait time in the emergency department is about that. This is not something that people consider an emergency in some senses, but the sequelae of complications from a missed dialysis appointment would be much more detrimental to the patient and, quite frankly, our hospital. if we don't take care of this early. So the patient also received some counseling about how to manage his illness in a new city, primary care doctor options, and a variety, various other local support systems that we offer at San Francisco General. It was odd to me that he moved up with no plan, but with a bit more questioning, we found out that he was in an abusive home and it really was emergent that he get out of town.
Oh man.
Yeah.
Okay. Well, you know, that's the hard part. It's like, sometimes you meet this patient and you're like, you're all in your own head about how like, this patient, this is a preventable medical issue. Like they should have just been taking better care of themselves.
Okay.
But this patient really needed resources even beyond the dialysis. They needed a safe place. And what's great is that you're able to provide that for them in the emergency department. Okay,
Yeah.
so yeah, like social work is so critical because they often have a line on a lot of different resources that go outside of the traditional organic medical treatment. But especially with dialysis patients, we're looking for the emergencies, right? Like, because it's less acceptable to say I've missed dialysis for the past week because I've been beaten and tortured in my home. That's not acceptable to say sometimes socially. It's a lot easier to say, oh yeah, I've been hitting my dialysis regularly Monday, Wednesday, Friday without fail. That's the more socially acceptable thing to say. It can be hard to admit, yeah, I had to leave my house in the middle of the night and I've been off of my dialysis because I've been on the run from
Right.
people. Okay, so people don't want to get into that. So in these patients who are kind of on the margins here, just go ahead and get your basics. Get your EKG straight off the bat, looking for, the bizarre EKG morphologies of hyperkalemia, then nail down the stability of their electrolytes with, the CMP, get a CBC to look for any sort of anemia of chronic disease or other stuff like that. Get the nephrologist on the team. Worst case, this patient just could have come back to the ER every day, and sometimes that kind of happens. Not to spoil the next segment here, but that's kind of the worst case scenario. Sometimes with time, which again maybe is our most precious resource in the ER, with time, some of these things can be sussed out and the patients can be connected into the right resource. Take a breath, recognize, like I think we kind of maybe mentioned earlier, that everyone is going through a little bit of something that you don't have no idea about. And so give them that grace, give yourself that grace to know, to say, maybe there's something I'm not hearing or I'm not seeing here that I'm not aware of. Whatever it is, that's happening. No big deal. I'm here to help this person today.
Yeah. So that brings me to our next case, Mike, of a patient who frequents the emergency department every single day.
Oh, yeah. These are really difficult patients, the daily ER utilizer. And sometimes there are patients where it's like, I wish they only came once a day. But because I have this great kind of, the Care Everywhere network, I can see that the patient was an RED in the morning and was at the other ED at lunch, and it's dinner time now and they're back to RED. So yeah, like sometimes I wish these patients were just daily utilizers.
Yeah. So this patient might have some underlying medical problem, right? And it occasionally gets a workup for chest pain or shortness of breath. But once their medical exam is done, they often state to you that they're now suicidal. This is a frequent scenario for the patients that come in and day out in many emergency departments because they're homeless. They have They have a difficult ability or reasons for using outpatient resources, even when we provide them. They may have bipolar, schizophrenic, or manipulative underlying mental health issues. And these patients can be very difficult because sometimes, as I mentioned, they can have real medical problems that need attention. Many of them are methamphetamine abusers or potentially have had an overdose of fentanyl or another drug. And a lot of patients that I see who are homeless are in like their 40s or 50s, and they're like incredibly resilient human beings. It's really incredible what they can put their bodies through and then live to be 100. So I have several patients who have been abusing methamphetamines for years. They have heart failure, renal failure, but they're trucking along. And many times they come to the ED, and of course they have, a kind and caring attitude, considerate from all of us. We do offer them treatment. But what do you do when the patient has finished their workup and they're stable and they're ready for discharge, but they don't have a home to go to?
A lot of your ERs that you work in are going to have this kind of pre-printed resource that talks about locations for shelters, and hopefully you're in a town where there are multiple options, okay? But if you're like, my town, a lot of these shelters are at capacity. or at a certain time of day they just close. And so if the person's there at 2 o'clock in the morning, maybe all those shelters have shut their doors for the morning. And so sometimes it takes talking to social work in the middle of the night if you have the luxury of that resources. And it's so nice when that is, and they can tell you, oh yeah, I know XYZ are closed right now, but A and B are open currently at 2 a.m. I can get them in. And so get social work on your team, help them to get on board with this patient and involved in the care. The second step to consider is if this patient who has gone through the entire medical workup and now kind of drops the bomb at the very end, like, oh, incidentally, I'm suicidal. And it's like, okay,
Yeah.
we screened you for that when you came in and you said no. And you said nothing about that over the past 3 or 4 hours. But now when the nurse is handing you discharge paperwork, the nurse comes back around to me and says, Mike, now the patient's saying he wants to hurt themselves. You have to figure, like, well, how do I assess whether this patient has truly an immediate psychological need and should go to be evaluated by our behavioral health team?
Yeah, Rick Bucata and Greg Henry had talked about this in great length on Risk Management Monthly in the past. And, taking these complaints seriously. Obviously, we take them seriously. We don't just ignore them. But our campus, we have something called PES, which is our psychiatric evaluation site where patients get an overnight stay. Oftentimes, they get placed back on their medications. They can take a shower. They can get plugged into our outpatient clinic or therapy. But unfortunately, patients abuse this system. Like, I had one of my psychiatrists say the other day to a patient, like, PES is a place that you go to once. Okay, it's one time we get you back on your feet, maybe twice, but like you can't be going to PES every single day when you're not getting, the food or shelter that you want from an emergency department hospital when you don't have a life-threatening medical condition. So again, unfortunately, patients manipulate and abuse the system, and they say how and they say when. And the reason why I'm bringing this up is because I feel like creating a rapport with these patients is incredibly helpful. Now, first of all, remember I said if they're telling you they're suicidal, you can't just brush that off. You need to re-examine the patient, talk to the patient, and take it seriously. But let's face it, we've said this before. You're their everyday friend. You're their personal doctor. You're their personal nurse, whatever you want to call it. And they come in sometimes just to say hi. Sometimes they're a jerk. Sometimes they're nice. Sometimes they follow directions. Sometimes they don't.
I haven't thought about this person in a long time, but we had this day, and I think I've said this on the podcast before, so sorry, longtime listeners, if I'm saying this again. But I had this patient come in, and he was a daily ED utilizer at another shop I was at, and I was talking to him, and I was really trying to have a heart to heart with this guy, and I was like, so, like, sir, you just got done telling me that today you're the same as you are every single day. So why are you here? Like, what made you decide to come into the emergency department? And he said, this guy could not lie directly to me. Like, he had just his personality was not what I'm convinced could summon a lie. And he looked straight into my face and he said, because when I come and talk to you, you make me feel better. I was like, I don't really give you a lot to make you feel better usually, so it's bizarre that like that's what you think I'm going to do for you today. But like that's that okay? Like you got me, like I can't argue with that. There is a very popular book out there right now called Never Split the Difference. And the primary author is a guy named Chris Voss. Chris Voss was the lead negotiator for international hostage situations for the FBI for years before he retired relatively recently. And he's been on kind of like the podcast and circuit ever since then. And he offers some really interesting tactics and strategies in his book about hostage negotiation that I think, frankly, can be applied very well to our everyday roles in the emergency department, because often we are in these, amplified, activated discussions with people in crisis. And so, how is that much different from a hostage negotiator or a hostage taker? He suggests that in a negotiation, there are these phenomenon called black swans. And the black swans are these unknown variables that we didn't even know were things that were out there to be discovered. And if you know what the black swan is, then that can break open the discussion or the confrontation. And so, what helps me in situations with these people with severe unmet needs, whether they are, medical or social or psychological, is at least reminding myself to be open to the possibility. Maybe there is something I don't know here. Because if you think you know everything, I'm not going to say you. If I think I know everything when I walk into a situation, sometimes I am surprised unpleasantly. And so it's better for me to walk in a situation going, let me just be open to the possibility of a black swan, something I don't know, a variable that could change the entire discussion. And it maybe takes me a few extra steps or minutes to discuss things with the patient, with a relative, with a friend, with another ER colleague who maybe has taken care of this patient before, to uncover those unknown unknowns, the black swans. But those investments have often paid off in major ways. If nothing else, I can make better decisions about this patient in the future.
Yeah, so let me just move forward on the patient who says, I'm here for a medical complaint. They don't say anything about being suicidal. And then upon discharge, they're now suicidal. And I'm not saying that he's not suicidal, but for the last 17 years, he has daily visits to our department and others, sometimes 3 a day with the same presentation. Literally $1 million workups. Don't buy him an admission. When he gets discharged, he says he's suicidal. It's very manipulative. It's very tricky, but I'm not saying the guy's lying. I bet he's depressed every single day, but we have not served him right, in my opinion.
I, I can think of many different ways this patient should be served, frankly, but I think you're thinking of something a little different than I am. What do you mean by that?
Yeah, so I think we've done medical screening exams and sometimes tests, but we haven't actually gotten to the root of the problem. And now I know that that's not necessarily the ED person's job, especially when you have a patient coming in every single day. Get to know them, figure out the best way to discharge them or admit them quickly. That's what you're thinking, but maybe you should think more about their underlying signs, symptoms, presentation, and background.
Okay, so if I'm picking up what you're putting down, um, like so let's say somebody comes in who has abdominal pain, so to speak. This is your ED utilizer every day, and they come, okay, I've got abdominal pain. So like often we will knee jerk like, oh, you've got abdominal pain, CBC, CMP, lipase, urinalysis, and they go off. You don't see them for an hour and a half, and then finally those results come back, and you go in and see the patient, and they are usually knocked out, dead asleep, and you kind of have to wake them up and go like, hey, your labs are fine.
Mm-hmm.
And it's an hour and a half in now or 2 hours in, and now they say, well, I'm suicidal. So like are you saying kind of like this knee-jerk ordering of labs and tests based on this known repeat utilizer? You think that what's causing the problem here, do you think?
Yeah, you guys are all in denial, okay? That's pretty much what I'm saying here. Like these patients, I'm not, of course, you can do a workup if you want to. But for this particular patient, and not all patients are the same, we sat down, we had a discussion. I talked with him in a private area. I realize that not everybody has a psychiatrist who roams around the emergency department in a PES area where patients can go. We're lucky we do have that. But together, we can talk to patients, see if we can get them compliant with care. So it turned out that this guy, every single time the patient wanted to refill the medication at a pharmacy, the same pharmacist for the last 15 years has treated him very poorly. Like, I'm not even kidding. This has
Oh,
been going on forever. And therefore, the patient avoids going to get the medication that is, by the way, free to him just because of the pharmacist's attitude. All right. Now, this may sound ridiculous to you for the patient to come back and be non-compliant with their medication, but all we had to do was change the pharmacy. And lo and behold, there he went and picked up the medication. And I could go on and on and on about small personal tidbits I've learned from my daily utilizers in the ED. But the lesson here is to discuss the patient simply some more social engagement questions. Okay. So to figure out what really set them off today. Other patients, they don't like the rain. They simply need a change of clothes. They think they need to lie and say that they have a medical complaint in order to get seen and get those clothes. Turns out they don't. They also have they get more attention if they say that they're suicidal, even when they're not. And again, I'm not saying that people aren't suicidal, but you are the one that's going to find that out by asking more questions. So you can discuss with them up front that they can still obtain resources without necessarily having a full medical workup or fictional chest pain. And they're less likely to stay, 13 hours and get unnecessary workups or needle sticks or what have you.
Yeah, and I can, think in my head of somebody who would do something like this a lot. He would come to the emergency department and he would say he had a behavioral health complaint, but the second he got back to our equivalent of PES, he would say like, I really just need something to eat.
Yeah.
And it's like, oh my gosh, this person required essentially the intervention of six different people to finally get to the point where he felt comfortable saying, I'm hungry. And so I tried my best. Like once we figured that out, I tried to tell him every time I saw him, all you have to do is tell the front desk before you check in if you're hungry. Like, can you try to do that instead of creating this scenario that requires, like, frankly, I'm delaying the sandwich. I'm delaying the thing you need
Right.
if you say the thing, all right, about needing behavioral health care. Now, at the same time, I don't want to necessarily like encourage this guy to come to the front desk all the time and tell them that he's hungry, but in the end, we are saving some time here, even if they do come repeatedly just for that. And that required us understanding the patient and looking back through records and seeing patterns here, and not just treating them as their individual visit on that day and kind of just like churning the waiting room. Okay. And maybe when you do that, at least for this patient, it made this patient easier for me to manage, both like, in a flow level as well as just my personally how I manage this. These patients can be almost institutionalized in a way. They know the system, they know what they have to say, they understand your limitations. So it's just a really interesting situation that we find ourselves in. I think what I've kind of come down to is that patients with these problems, they're still going to come, regardless of how hard or little I work and how much I obsess or not think about these patients. Regardless of what I do or don't do, these patients will come and come often and come every day. But I too, Martha, have been rewarded by taking a little extra time in my day and trying to find that kind of a black swan in that patient's care. What is really going on here? What is the thing I don't know that you haven't told me yet that brings you back over and over and over to emergency department? That's made a change both in the patient's lives and often in my own life as well.
Yeah. So, I use this tactic with employees that people work with, or bosses or doctors or nurses that everyone says, oh man, so and so's here today. I do not like them. I do not like working with them. I do not like talking to them. And when I hear somebody say something like that, I'm like, yeah, where's this person? I want to go talk to him. I want to be friends with them. Let me figure out what's going on. And it turns out, usually, I tell you, 99% of the time, that person is hated for a stupid reason that doesn't even matter, and nobody really got a chance to get to know them. And, I'm not going to say names of people that have been hated in my departments.
If you're listening, Jim, what's up?
Nah.
Just kidding. I don't know,
So,
Jim.
no, I mean, honestly, I just, I hear people say, oh, so-and-so is here. Please don't make me see him. I'll go see him. What's the problem? If they're violent or abusive, like that's a different story. Nobody wants, to get into that situation. But
Right.
if it's just like this person's annoying and they're here and I just saw them yesterday, like, okay, I'll go see them, because you should really take pride in knowing as much as you do, like being able to handle that situation. Not only were you a peers, thank you. I mean, again, you're not trying to create a situation where people are taking advantage of you. But think about it. If you skip getting irritated and blasting patients for, quote, coming every day, it's okay to still ask the patient, look, we see you every day and we feel like we aren't really helping you. We're not really serving you. And we want to help you. How can we do that for you? It's a great phrase. I've said it a lot, and I think it makes all the difference.
And it's funny that, like, you probably haven't read this Voss book at all, but like that is often a tactic he suggests, is like put it back in the other person's court. Like how can we help you? Like give them the rope instead of you trying to impose your thoughts as far as what I think I should do for you, ask the patient like, what were you hoping you know what were you hoping we could do for you today? What is the things that how can we help? What can we do? What would you like us to do? Give it back to them. And
Right.
sometimes you're surprised as far as what you get here. uh, Martha, we had a couple other things to talk about, but I think what I'll do is kind of skip along to a little something sweet. We haven't talked about something sweet in a long time. I want to resurrect something sweet, okay?
Yeah.
And
Well,
go
we're
ahead.
right on 1 hour, and I really wanted
Okay.
to include this month because I really appreciate what ASAP's been doing recently, and I really like ASAP now. I think that they have some good stuff that's worth your time. So it's really just like, hey, can you get a chance to check one of these things out? So this piece in ASAP this month, it's about lower UTIs and when to order a urinalysis. So great little piece that breaks it down, and they basically have 3 categories of what they're saying for urinalysis here. So patient with no lower UTI symptoms, do not order a urinalysis. So a UTI is defined as a combination of UTI symptoms and a positive urine culture for pathogenic bacteria. In the absence of lower UTI symptoms like dysuria, urgency, frequency, by definition, the patient does not have a UTI and therefore does not need treatment with antibiotics, right? So even without any UTI symptom, a young female patient has around 5% chance of having a little bacteria in there. So this is, of course, is a bit different for pregnant patients. So an HCG in females of childbearing age should be collected. The next kind of thought they said here is patients with multiple UTI symptoms. Controversial statement here. Do not order a urinalysis. Well, so they argue here that what about a young female patient with dysuria and urinary frequency who is telling you that she thinks she has a UTI? As long as she's not having vaginal discomfort or discharge, which could potentially mean STD or STI, this patient has about a 90% chance of having a UTI. Even when a negative leukocyte esterase and nitrate might appear, this patient still has a 71% chance of a UTI. So if you withhold treatment based on a negative urinalysis, you would be undertreating nearly 3/4 of these patients. So I find this one controversial and up for discussion because this lady wants a UA result, right? So I say proceed with caution here despite the recommendations because there are many variables and a UA is cheap to get. What you do want to order on is a culture. Finally, patient with a single UTI symptom. Order a urinalysis is the suggestion. So I'm going to leave this one for you to check out. There's a lot to consider and always good to brush up on the is this a really UTI or is it something else discussion. So check that out. We'll put the link to the short read in our liner notes.
It's really interesting. We've come like full circle in a way. Like one of our very first podcast episodes was about recurrent urinary tract infection and kind of like the pearls and pitfalls there, And I think it's a very powerful thing to ask the question of the patient, hey, have you had a urinary tract infection before? Yes. Does this feel like the last time you had a urinary tract infection? And if they say yes, that's a very powerful question to ask. And that's been shown by certain studies to be very highly sensitive in terms of somebody having a urinary tract infection. Of course, if they say, yeah, and I've had 17 in the past year, okay, maybe we pump the brakes here a little bit and try to figure out 17. That's a few more than usual. Like how do we know you had a urinary tract infection? Did you get cultures done? Have you ever seen a urologist? We're gonna put links to that initial podcast episode down as well. I think it pairs quite nicely here, like a red wine and some steak, with this little something sweet that you mentioned. Okay, considering the patient who has had multiple urinary tract infections and they want treatment, they want to feel better. What do you do for these patients? Okay. What is the way you can kind of minimize harm, maximize data, and also not miss something? So
Yeah.
that was
And
great.
Mike, why don't you end on money? Because, everybody wants to know about money.
We're starting the podcast with drugs and ending with money. A lot of
Yeah.
some of our listeners' favorite topics here, frankly. Okay. But first off, yeah, 2view.fireside.fm, the number 2view.fireside.fm is where you're going to see a link to this ASAP Now article, which is a great publication. Another great publication is the American Academy of PA's yearly salary report. Okay. Every year, the AAPA puts out a salary report that you get when you're a member of AAPA. And according to respondents to their survey, survey. So right away, there is some potential for like missed or like manipulated data in a way because these are surveys that people are voluntarily responding to. But regardless, in 2023, the median compensation for the PA increased to $127,000, up from $120,000 a year in 2022. Something sweet indeed. And listener, if you happen to know the right people up in the C-suite in your practice setting, I think the next point from the study is super important. PAs who reported feeling professionally fulfilled. And don't we all want our PAs to feel professionally fulfilled, right? PAs who reported feeling professionally fulfilled often had a higher median compensation than their peers. Something to think about for those of you who want their PAs to be fulfilled is, hey, show me the quan and I'll show you my fulfillment here potentially.
Awesome. All right. So let's finish up here and get going. 2View trivia answer. Okay, so last show we asked the question. We all know that triage comes from the French word sorting. But who was the first person back in the 1800s to use the French word?
I would say trier.
Trier. Okay, whatever.
That was great.
To describe the process of medical sorting, and who did he work for?
I've been waiting an entire month to say this guy's name. So that year, Baron Dominique Jean Larrey, the Surgeon-in-Chief of Napoleon's Imperial Guard, laid the groundwork for what would eventually become modern triage. And his thought process was that we need to treat the wounded according to the observed gravity of their injuries and the urgency of medical care, regardless of their rank or nationality. Dr. Jean Larrey, I think you'd find a great place to work in my emergency department with that mentality, treating with regards to gravity and urgency regardless of rank or nationality. I can't agree with that more. In terms of our winner this month, congratulations to Anonymous. The person did not want to be named here. They're a rabid listener to the podcast. They're just a little bit shy, and so congratulations to you, shy guy and shy gal out there. You'll be getting a nice discount off of our advanced emergency medicine boot camp streaming course, or really any other streaming course you want. Just let us know. We'll send you Meg Dipple's email address, and you can kind of go from there. Martha,
right.
You've got
new
question. Yeah, based off of your previous topic today.
Yeah, so here's a question. How many severe sunburns early in life may double the risk for developing melanoma later in life? And to prevent that, how often should you apply sunscreen?
So there we go. It's a two-part question.'re going to need your two-part answer, and you can send it in to us at our email address. That is 2viewcast@gmail.com. The number 2viewcast@gmail.com. Well, that is our show, folks. More information on the original and advanced emergency medicine boot camps, the emergency medicine and acute course redesigned for 2024. We've got the mastering pediatric emergencies. I want to say mastering emergency pediatrics, but same sort of thing. You get the idea, right? Potato, potato. Any of our courses, information on those courses is available at the Center for Medical Education website. That is www.ccme.org, www.ccme.org. And thank you. Thanks for listening and attending this podcast, this iteration of the 2View. You can subscribe and rate us, and we wish you would, on Apple iTunes Podcast, Spotify, and YouTube Music. Search for 2View Emergency. That's the number 2View Emergency. It'll come right up. Ratings help us climb the charts so that other clinicians get to some 2View goodness like you are today. If you like YouTube and video, you want to see the video version of the blog instead, you want to guess how old Martha's printer is in the background of her shot here, then you can get on the website and get on YouTube and search for Center for Medical Education. You can catch the video version of our podcast. Don't forget our website where you can go next level on any topics from any of our episodes, including all the papers and sites we refer to. That's 2view.fireside.fm. Our audio and video engineers are Ricky Bucata and Dave Pett. Show notes are by Meg Dipple. It looks like a really nice printer, by the way.
It's brand new.
It looks new.
Thanks again for tuning in, friends in EM. Share this podcast with a friend. Share your thoughts via email. And thanks for sharing your time with us on the 2View. Have a good day and a great shift.
It does look new.